So now we'll move for the next session. I'm gonna chair it because unfortunately I think Dr. Wissam is not here and Dr. Muhammad Abdulaziz is not here. They are still in the work. So the next session, we are not late because there is one lecture is already down. So hypertension update to 2024, exploring uncommon presentation and emerging insights. So the first presentation is Dr. Sharif Bakir. No need for introduction, everyone knows him. So Dr. Sharif is gonna give us a talk about understanding of hypertension in 2024. Then Dr. Tamer again is gonna come and talk about case presentation, about unusual case of hypertensive emergency. And usually case presentation is, more exciting. Resistant hypertension and sleep apnea by Dr. Amal. So we will start with Dr. Sharif. Dr. Sharif, floor is all yours.
Thank you very much. It's great pleasure and honor for me to be here, and we want to thank Dr. Ahmed Munir for all what he have done every year, and this is very difficult to arrange a meeting. When we talk about hypertension, I think all the time say why we come to listen to hypertension, but because up till now we don't understand the hypertension. Let me to tell you as a cardiologist, whatever any cardiac disease you have, the reason is three: cholesterol, diabetes, and the hypertension. Ischemia is related to this. Everything is related to that. So hypertension is not a simple. We have to also to understand that hypertension is genetic. And 50 to 40% of the people who are hypertensive, you will find family history. They are hypertensive. So it is a genetic disease. You have to understand. So when you see someone, you have to look for the family. And to understand that there are a lot of genes, 100 genes regarding the blood pressure. Because now we are in the era of genes, but it's still costly. But to understand that it is a heritable disease. Everybody know this picture, of course. This is in 1945 when we thought that hypertension is a very good compensatory mechanism, and this indicates that your heart is very good. So at that time, 1945, there was a study statement by Dr. Paul Dudley White that if somebody tried to treat hypertension, he's an idiot. And the blood pressure of President Roosevelt during that meeting, he died 4 months after this meeting. His blood pressure was 270 systolic, and when he died 4 months later, his blood pressure was 370 systolic. Why I am showing, and since 1937, his blood pressure was increasing. And at that time, everybody was happy with this high blood pressure. So, what is hypertension? Everybody is saying that we understand hypertension. Is it number? Is hypertension is number? For sure is not, because 370 and he's still alive. So what we said hypertension, I like this picture I presented in the last 20 years. We said all the time what we said, don't always believe what you see. Why? Because this is the chair. Why I am showing you this? To tell you that when you look to patient with hypertension, does not mean it is number, because you all the time think about hypertension as a number. To convince you that it is not a number, look to the Joint National Committee when they start. First, they said 200 is a borderline up to 160. And then they said, no, please don't believe us, will it change? They give you Joint National Committee 4. They said, no, make it the borderline 160 and systolic, and there is something called normal up to 140. And they said borderline. I don't understand the meaning of borderline. There is no borderline cancer, but never mind. At that time, they told us this is borderline. And then they came at Joint National Committee 5. They say, sorry, don't believe us. We'll change the number. So now we have a lot of complicated normal, high normal, mild, moderate, severe, very severe. And then after that, they came and tell us, no, sorry. We changed, the number have been changed, and they told us, forget about normal and the high normal. Now we will go to stage 1, but instead of mild, stage 2, and instead of moderate, and then in stage 3. And then after that, they came and say, no, don't believe me. By the way, all these guidelines have been by hundreds of doctors meeting together for 4 years, taking money to give us this. And then they said, now we had Joint National Committee 7, and we said, don't say stage 3, start stage 1 and 2. And then, finally, there came the Accord trial, if you remember. And the Accord trial said that trial evaluate the effect of targeting systolic blood pressure of 120 to 140. And the conclusion of the target tell us no difference. They said the result to provide no conclusive evidence that intensive blood pressure reduction is good. And we accept that. And then after that, they give us the sprint trial. Came and tell us, no, don't believe the Accord trial. I am saying 120 is much better. And then the guideline changed. And then came Joint National Committee 8 to tell us, no, we want the lower is the better. See how many times that we change the number? So for sure it is not number. And then the tale of two guides, we have the the American 2017, European 2018. One of them said the upper limit 130, the other one said the upper limit is 140. And they said, don't believe, and we start to be confused between them. And then the people who make the Accord trial came to us after 4 years, and they said, sorry, we have done a mistake in the Accord trial. What is the mistake? They said, when after 3 years, when we follow this patient, we find 120 is better. So we are sorry about 140, and we said there is no difference. So now we said, so it seemed that what is hypertension? It is number. The answer is no. It is not number, because we don't know the number. What is number? Now we know that 130 is better, it's okay. Now we'll go to, is hypertensive is a hemodynamic disorder? I remember Dr. Abdullah Shahab, he invited me a meeting before, because all the time he asked me, hey, what is hypertension? So we said, although historically defined as an elevated blood pressure alone, but hypertension is characterized by abnormalities of cardiac output, systemic vascular resistance, and arterial compliance. So you have to understand this. This is very important. This hemodynamic aspect of the hypertension have implication for the diagnosis, the risk stratification, and the treatment, as I will show it to you in the next few slides. So we have to understand that it is not number, it is a cardiac output. Now look to the mechanism of hypertension. What is the cause of hypertension? Blood pressure is cardiac output times total peripheral resistance, heart rate, stroke volume, arterial pressure, venous pressure. And this is why the treatment of hypertension cannot be by one single drug. If you look to the guideline, as I will show it to you, 2023, they said you have to start by dual combination. Why? To take two mechanisms, not one mechanism for the blood pressure. So it is wrong to consider hypertension as isolated disease. It is not an isolated disease. The truth is, it is only a marker of a bigger problem. And you have to deal with patients like that. Hypertension is asymptomatic multi-organ system disease, and it is asymptomatic. Rosfeld, his blood pressure was 270, and they have no problem, nothing, no headache, nothing. So, hypertension, diabetes, dyslipidemia, obesity, all these are coexisting together. And when you're dealing with hypertension, you have to deal that hypertension is a risk in the presence of other disease. This is very important when you manage the hypertension. How hypertension can induce atherosclerosis, hemodynamic factor, very simple. Hypertension promotes turbulence, and this turbulence would lead to the deposition of the lipid and initiating the cardiovascular disease. How hypertension and the atherosclerotic common factor? Yes, because hypertension can affect the endothelial system, and with this growing factor lead to cardiovascular damage and disappearance of endothelium deriving laxation factor from the endothelium system and secretion of the endothelin. Also, another important point, the smooth proliferation. Main step in the atherosclerotic process is atherosclerosis smooth proliferation, and the hypertension is the main cause for that. So when you deal with hypertension, you have to understand it is not a number. You have to look to the patient and what other comorbidity that he have. So, endothelial dysfunction, blood pressure, induce organ damage. The question is, how many endothelial cells we have in our body? We have more than 4. And this is why we'll find the endothelial in the liver is different from the endothelial in the kidney, liver different from any other organ. And this is why we find some people with hypertension develop, for example, eye problem before brain, or kidney before heart, heart before kidney, because this depends on the effect of the hypertension on this different endothelial cell. And of course, also the most important thing is the decreased sexual ability. This is very important because the most important pleasure in the world is sex. So we have to understand when somebody loses this, he loses the need for living. So hypertension is a multi-systemic and polygenic disease. You have to look for that. It is not a number. And hypertension and metabolic syndrome. 45 to 50% of the people in the United Arab Emirates over 30, they are obese. And we thank God now that we have treatment for obesity. But look to this. Cardiovascular disease increase in hypertensive diabetics than people who are not diabetic. Obesity will lead to diabetes. Diabetes with hypertension is a very bad combination. So, insulin resistance and hypertension. This is very important. We have to understand that obesity, insulin resistance lead to diabetes, hypertension, vasculopathy, diabetic nephropathy, and so on. So hypertension causes diabetes? Yes. Hypertension can cause diabetes. How? In hypertensive muscle switch to type 2 fast switch fibers which are insulin resistant. So it is not a number. Hypertension is a hemodynamic disease. And we have to know that the relation between the diabetes and the hypertension is coexisting. And it is very important to understand. So the two terrorists you have it in your life is diabetes and hypertension. If you remember the study, I forget the name. If you remember this, the name of the study, I forget it. This is the, never mind. This was a diabetic study, and it had been shown that when you treat diabetes, No, it's not advanced. It is the diabetic, never mind. UKPDS trial. UKPDS trial. It is the most important trial. Yeah, it is written there, very stupid. Yeah. Never mind, old age. So the problem, if you look to UKPDS trial was a diabetic trial. Diabetic trial. It's not a hypertensive trial. And what UKPDS tell us, if you treat diabetes, you are not doing anything. You reduce stroke by 5%, but if you treat blood pressure in the UKPDS trial, you reduce it by 44%. It is diabetic trial. Diabetic, not a hypertensive trial. This is so tight diabetic control does not give you anything, while tight blood pressure control give you the best. But when they follow UKPDS trial after 7 years, they discover that yes, when you treat tight control of diabetes, you can get the benefit. So the benefit came from treating the hypertension. So to cut a long story short, important risk factor for vascular endothelial dysfunction, hypertension, chronic inflammation, insulin, all of this is starting by the hypertension. And this is Eugene Brunwald in 1991. They asked him in a meeting in American College of Cardiology 2011. I was attending this lecture by him. And they asked him, what is the most common cause of heart failure? He said, hypertension. Once you are normotensive, you are protected. Once you start to be hypertensive and not treated, because most of the people of hypertension are not taking the treatment because of no symptoms, they will end it in heart failure. So, to cut a long story short, hemodynamics, we have to know that we have young elastic vessel for the people below 40 or below 35, while old people above 30, not old, but people above 35, 40, they have non-elastic. What does it mean? The young compliance of the arteries is like that. When the blood pressure is okay, it will be the speed of the vessel inside the arteries, okay? so peripheral amplification and increased coronary flow. But when you became old little bit, which means that stiffness of the artery, will lead to increased vascular afterload, decreased coronary perfusion, and this will lead to increased oxygen consumption and or recognize wide brachial artery pulse pressure. So again, to return back to the mechanism of hypertension, as I said, it is not one mechanism, it is a complex, and this is why we know that drug needed to treat hypertension, to according to which kind of drug, which drug we should use for hypertension. The guideline tell us any drug but reduce your blood pressure, but according to the hypertensive theory, any hypertensive drug which also possesses anti-erythrogenic properties might be beneficial, and this is why when you treat your patient, you have not to think about the number. Your patient is this one. It is not this one. So forget about the number and think about this. Look to this. This is a 55 years old male, have all the risk factor, but he controlled his blood pressure, 120. His risk for the next 4 years to develop a problem, 19%. Let us to change his blood pressure from 120 to 140 according to the Framingham study. Look what is the risk now, 48%. So hypertension is the joker. To be put it in any disease will make it worse. So it is not one size fits all. As we know life, we are tall, young, short, so there are many patients. Some people you need sympathetic more, you need renin more, you need total body sodium more. You have to look for your patient, forget about the number. And this is the new guideline, 2023. They said start by dual combination, not by single drug. You have to start by dual combination, and based on that you will decide. So this is why, because this will affect the mechanism of blood pressure. Please don't forget sleep apnea. Thank you very much.
Excellent. Very good. Ahmed, if I may ask a question to Sharif, great talk as always. So is a dynamic, is a marker, is a risk, is a disease, is emergency? It could be anything.
Yeah.
So it depends on so the numbers still drive us to start medication. I know you said numbers not a...
No, I don't say number is not important, but I'm trying to say...
I understand you, but I'm saying still the number is the issue.
Yeah.
Going back to what you said at the beginning, you said genetic. I mean, genetic 50%.
Yeah.
Think, I looked at the references.
Yeah.
Look at the references. It's really is a joke. I think we should not say genetic. We should say environmental, then say epigenic. Epigenic, that means environmental, initiate
let us
genetic, that means you have no rule.
No.
That's a big problem.
About genetic, you have to understand. Gene is like that. Gene is like key and lock theory. What is the key and lock theory? The key and lock theory is like that. To enter this room, you need to have the key to open the lock. The key is the environment. The lock is the gene. So this is how the environment are interlocking with the gene. If you have a gun and put it in your table with is no bullet inside, there is no harm. But if you put the gun with the bullet, there is the harm. So the gun is the gene. The bullet is the environment. When you put it together, here is the harm. You get my point? Okay.
Thank you very much. Doctora, there is a question.
Do you regard, what about the age and related to the numbers? I mean, you said it's not a number, but what about
the
aging?
age?
Do you
Okay.
consider a person who has above 50 or about 60 years to have the same numbers of the patient?
Yeah, this question is very important. It has been raised in Joint National Committee 8 because they try to give different number to the age. And they said sometimes above 50, you can reach up to 60. But I will ask you, what is the age? There is nothing called age. We have 2 ages in our life. No, actually we have 3 ages in our life. One is called chronological age, which have no importance at all. Why? Because you can sit with one of your friends, same age like you, was with you in the school, but she looks older. And someone looks younger. Why? Because we have something called biological age. And this biological age is the most important, not the real age. I can have seen one patient 50, but looks like 70. Another patient 50, looks like 20. So age, there is nothing called age. Why? Because in our body, we have two types of the cell die by two things. Something called necrosis and something called apoptosis. What is the difference between necrosis and apoptosis? Necrosis, cell death due to disease. Apoptosis, each cell in your body have a certain time after which it's suicide and another cell come. This time is variable. I can prolong it or shorten by the risk factor. So my age could be 70, but biological age is 40. My age could be 40, but biological age is 60. And this is why the age have been failed in Joint National Committee 8, and they return back to say all the individuals should have blood pressure 130, and if you have a risk factor, even go lower. You didn't ask me about what is the third age. I said the first age is chronological, the second age is biological.
I know the third.
The third age, how you feel yourself. I feel I am young. I have the right to feel I am young. This is my age and I will have this age.
The third age is the age when you get married. So this is the most
No, when you get married, this is a big risk factor. Okay? Any other questions?
Dr. Sharif, thank you very much.
Thank you.
Now I invite my friend, Dr. Tamer. And Tamer is going to give us a case presentation about the unusual case of hypertensive emergency. So now we'll go back to the case presentations.
Okay, good afternoon, everybody. So this is going to be an interesting case. So actually, I got a call from the ER department that they have this 33-year-old female. She's known hypertension. She has not been taking medications. She was diagnosed 1 year back, and she's not on medications. And she presented to the ER complaining from severe headache, dizziness. When they checked her blood pressure, it was 195 over 105. So they called me to consultation, check this patient. So actually, heart rate was 65. Cardiac auscultation was normal, chest was clear, her Galaxocoma scale was normal, no neurological deficit. She's a non-smoker, she doesn't have any past history, she has family history of hypertension. This is her ECG in the ER, so almost normal, nothing significant. And these are her labs when she arrived in the ER, so kidney functions are normal. And actually, this is her troponin. So usually, in the ER, our ER physicians are doing troponin for everybody. Patient coming for dizziness, for vomiting, they're doing troponin. We've been fighting for them for a long time not to do it unless it's something indicated. But anyways, they did troponin for her. It was, this is the trop I. It was 0.04, and the normal reference in our lab was 0.156. So slightly high. And usually you expect somebody coming with a hypertensive emergency, you expect that troponin might be slightly high. So anyways, we started this patient on labetalol infusion. We dropped her blood pressure to 140 over 90. She was shifted to the ICU, and we started her on oral medication, combination of valsartan, amlodipine, 5 over 160. The next day, the patient was off labetalol. She was on oral medications only. Her blood pressure was 140 systolic, 88 diastolic. The symptoms of headache and dizziness were gone, and she's not having chest pain. So what would be the next step? Would we discharge the patient? Would we do something else? Anybody would like to comment? So usually for me, I repeat the troponin the next day just to make sure. So if this is hypertension, you would expect that it would be either the same number or it's decreasing. You wouldn't expect to rise. I forgot to mention her echo is normal, just concentric LVH. Dr. Abdallah, you want to say something?
Yeah, so if you do a troponin and it's high, you're supposed to repeat it within 3 hours, not next day. I don't know. Why was that the reason?
Because we're not expecting that is something coronary. Because of the presentation, she's young, no risk factors, so we thought it just elevated from the hypertensive crisis or hypertensive in emergency.
I know you are expert cardiologist, but I think, somebody with hypertension coming with like that, troponin is high, my first thing to exclude is coronary artery disease, acute coronary syndrome.
Correct. So anyways, this is the second, this is her lipid profile. So we did a lipid profile the next day. So you can see that her LDL is high, 4.4. HDL is normal, triglycerides slightly high. And of course, total cholesterol is high. and this is the repeat troponin. So it was 0.04 initially, then it came up to 0.2. Still no chest pain, no ECG changes, the ECG is still the same. So what would be the next step?
I'll do the CT scan, CT coronary angio for the patient.
Okay, so we planned, as Dr. Abdullah said, for a CT coronary. We added for her bisoprolol 5 mg just to control the high heart rate during the scan. And this is the CT coronary. So we have a calcium score of 0, total coronary calcium score of 0. Dr. Hani likes calcium score, right? And this is the coronary angio report. So as you can see, cardiac rate 0, so LAD, left circumflex, left main, right coronary artery is completely normal. So next step, so we had a CT coronary normal, we have a mild rise in troponin, patient is asymptomatic, her blood pressure is controlled. So what would be the next step? Would we discharge her? Would we do something different? As echo is normal, there is no, we thought like maybe myocarditis, pericarditis, there is no echocardiographic. But why would the troponin be rising? Why would it rise the troponin?
For me, still I call this minoca, you know, it's myocardial infarction with non-obstructive. I mean, coronary is normal. That's where we miss minoca.
Okay. So, renal function is normal. Normal, completely normal. So I repeated troponin the next day, okay? So just to make sure that it's not rising, and we got 2.9. So this is where the controversy, we don't have an explanation for this significant rise of troponin. So you have a CT coronary, it's normal kidney function, the patient is asymptomatic, blood pressure is controlled. So what could be the cause? So we had a debate in the department about this patient. Anyways, I kept her overnight. I didn't want to discharge her until we find what the cause is. And this is troponin the following day. It's 6.9. Echo is normal, so echo is normal, ECG is normal, no symptoms.
So as I said, you know, it's still minoca for me. I treat for 1 month with antiplatelets, and I treat hypertension as well.
You wouldn't do something else, Dr. Abdullah?
That's it.
With this number?
I will treat with antiplatelets.
Okay.
I'm saying. Either ticagrelor with aspirin and also blood pressure medication and statin.
Okay. So we had a debate in the department about what the next step is. So with our cardiologist, some said you have a CT coronary that's normal, the patient is asymptomatic, put her on medication, discharge her, no need to do something different, but I was still not convinced. And the other half would say, do a coronary angio for her. We cannot let her go home like that with this elevated troponin. So this is the serial pattern since start, so 0.04, 0.2, then 2.9, and 6.9. So we decided to do a coronary angio for her. Okay, the patient was given a loading dose of ticagrelor and aspirin, and this is the coronary angiogram.
The only reason I do coronary angio if I'm not done it myself, CT, because I don't believe in radiologists to report the CT, unfortunately.
Okay, so this is, you can see, she has a subtotal OM, okay, despite of the CT is normal and the calcium score of 0. Okay, and you can see she has about a 30% lesion in the mid-LAD. RCA is non-dominant. And of course, we proceeded with PCI. And this is after post-PCI. So the patient was discharged, of course, on aspirin, atorvastatin 40, ticagrelor, her valsartan amlodipine 160/5, and bisoprolol 5 mg.
Dr. Tamer, so going back, you did the CT calcium scoring only, huh? You didn't do coronary
CT angiography.
How can you miss that like that? Yani? This is haram. Allah.
So that's the thing. So never rely on imaging alone. It has to make sense. So that's why the rise of troponin was not making sense. This rise is, you would suspect there is something going on in the coronary. So patient was treated, she was fine. I know she doesn't have any risk factors. We controlled her lipid profile when she came for the follow-up. Her LDL is 1.1. All her labs are fine, and she is completely stable.
I have just one comment, very nice. I just have only one comment. It doesn't mean that if you have a 0 calcium score, because 0 calcium score, there is no inter-observer differences. You calculate it, you can see it by yourself. Even if you have 0 calcium score and the clinical scenario is going with, as Dr. Abdullah said, is going with ACS or something, I think coronary angiogram should be. But my idea, zero calcium score doesn't mean normal coronaries at all.
Can I add something
Yeah.
to that, Ahmed? I think it's very important. Below 40 years old, don't depend on calcium scoring at all, because the plaque is not soft is there, and because I do CT scan myself, and I see a lot of surprises. So younger than 40, don't depend on the calcium scoring. Sharif.
High calcium score, if someone taking statin, does not mean anything, because high calcium score with statin, this means that the plaque is already become stable. And this is, I think, Valentine Foster have been giving a very big talk about that.
Yeah.
So calcium score is, my opinion, is the big sheet in this. I don't like it.
Okay. This is another thing. If you have a calcium score, that means you have advanced atherosclerosis. Okay? So basically, this patient needs to be started on a statin. So I know Dr. Sharif says, having a statin, of course, will not do anything to calcium scoring, but prevent the soft to be ruptured. That's the whole idea of statin. Thank you.
Any comment? Okay, so we are done. Thank you very much, Dr. Tamer. Very nice case presentation. Second talk, resistant hypertension and sleep apnea. Dr. Amal. Dr. Amal is a consultant cardiologist in Mediclinic, and she's with us from the first cardiology forum.
Thank you. Good evening, dear friends and colleagues. It is my pleasure to be between all of you, all stars of cardiology, and doctor is here, so nice to give presentation. My presentation today about resistant hypertension and sleep apnea. I'll start my presentation by case study. I have one patient, Ahmed. It is 46-year-old male. He came to clinic for treatment of resistant hypertension. Ahmed, he knew that his high blood pressure is high since he was in high school, but he started medication at the age of 42. His current regimen of medication, multiple drugs, Valsartan 320 in combination with hydrochlorothiazide 25, metoprolol 200 milligram, in addition to amlodipine 10 milligram. All this is medication, and although he is taking all this medication, still his blood pressure is uncontrolled, whether at clinic or at home. When we go to his medical history, Ahmed, he is obese, hyperlipidemic, impaired fasting sugar, hypothyroidism, and gout. This patient, he is strictly taking his antihypertensive medication. He is not taking any anti-inflammatory drug or any stimulant, in addition to lifestyle modification. His diet is salt-free, alcohol little is taking. Also, he is not smoking. In addition that, he did routinely exercise every day, and he succeeded to lose about 25 pounds in 4 years. Coming to his physical examination, his high blood pressure was 158/88. In addition that, his body mass index is 47 kg per square meter and pulse 51 regular. Out of obese appearance, everything is okay. When we go to laboratory routine laboratory test for kidney and thyroid done, all normal. ECG revealed mild LVH and sinus bradycardia, while echo also confirmed the presence of LVH. I need your opinion now. What we'll do next for Ahmed? To control his blood pressure, resistant blood pressure, advise follow-up blood pressure, a check in 3 months, increased extended release metoprolol to 300, or evaluate identical secondary causes of hypertension.
And you started metoprolol or been on metoprolol before?
Metoprolol 200.
Already been on that?
Yeah.
No, I think I revised my my medication again for this patient. I think it's not appropriate to be on metoprolol.
Yeah.
First, doctor, the guidelines excluded the beta blocker as a sole treatment of hypertension because it's not decreasing the central aortic pressure. So,
It is in addition. This will increase in medication. Already he is multiple medication. So my question is, should increase metoprolol? The answer should be no. Why? Because patient already in metoprolol 200 and his heart rate, he has bradycardia. So if I increase metoprolol, it will be symptomatic bradycardia and I will not benefit. Yes. Also, if I first one check after 3 months, what is the problem of this patient is obesity. So what expected after 3 months? He should go consideration to bariatric surgery, yes?
Sure.
But I will keep him till this time with this high blood pressure? Cannot be. So better to search for secondary causes for this resistant hypertension.
Did you check his aldosterone when you measure?
Yeah?
Aldosterone when you measure. Did you do that?
Next step, we did it. And at present of this time, we are investigating and then we'll start it later. Huh? Can you wait for a minute? We'll see what's done for this patient.
Okay.
All of us know that the hypertension is silent killer, and it is global main cause of global cardiovascular mortality and morbidity. Although his diagnosis is too much easy, as no much cost, still he has promote target organ damage and significant disease burden on the community if not treated. Hypertension is related with many comorbidities for the heart, for CNS, for vascular, for kidney. All of us know this. This slide showing the grades of hypertension according to European Society of Cardiology 2018. Same diagnosis of blood pressure as all mentioned, above 140/90 or above. But what is important in this slide, the definition of white coat effect. White coat effect is a discrepancy of more than 20/10 millimeter mercury between the clinic blood pressure and average daytime ABPM or home blood pressure monitoring at same time of diagnosis. Resistant hypertension. Why we need definition for resistant hypertension? It is important to define because we will define certain patient who has secondary causes of hypertension or resistant hypertension who can benefit from maneuver or medication. Okay? So, coming to definition, uncontrolled hypertension, blood pressure above the target. Resistant hypertension, it has definition. It is either office blood pressure that remain above the goal while the patient is taking 3 or more antihypertensive medication at optimal dose, including diuretic if possible, or blood pressure at the goal, but the patient receiving 4 antihypertensive medication or more, either above the goal with 3 or at a goal with 4. Now we'll go through approach to resistant hypertension. According to American Heart Association scientific statement, it has 6 steps for resistant hypertension. I'll start by one. First, exclude pseudo-resistance. What are the causes of pseudo-resistance? It can be blood pressure measuring technique, poor adherence, white coat effect. It is important for blood pressure measure to learn our stuff, how to check the blood pressure. Blood pressure should be checked at least twice, 1 minute apart. After 5 minutes of patient resting, his back is straight and supported, comfortable or suitable blood pressure cuff at the same level of right atrium. Come to poor adherence. Poor adherence, it can be patient-related, also healthcare related. Patient-related, this patient has health literacy. He has developed side effect from previous medication, forget, pill burden, has a number of pill. Cost of the medication. In addition, what is important, that hypertension is a silent disease, no symptoms, so patient will forget to take its medication. What is important? Health care related. Clinician burn it out. Busy clinic, patient have no time to be with the patient for good time. Why the good effect? I think we said definition. We said the definition of it. But when we suspect white coat effect, when uncontrolled blood pressure in clinic, while the patient has symptom of hypotension at home, diagnosis by ambulatory blood pressure monitoring or home blood pressure monitoring. I'll go to next step. Identify and reverse lifestyle factor. What is lifestyle factor? Excessive alcohol intake, high salt, it should be monitored. Physical inactivity, as us know that physical activity is important, at least from 30 to 45 minutes per day, and obesity reduction of weight is important. The third step, discontinue or reduce the interfering substance. Some medication already can affect resistant hypertension, like analgesic, non-steroidal anti-inflammatory, including aspirin, sympathomimetic, and stimulant also, glucocorticoid, alcohol, oral contraceptive, cyclosporin, erythropoietin, and natural licorice herbal. Fourth, screen for secondary hypertension. What is the most common cause of secondary hypertension? As Dr. Sharif mentioned, obstructive sleep apnea is the most common cause of secondary or resistant hypertension. Chronic kidney disease, renal vascular hypertension, primary hyperaldosteronism. Uncommon pheochromocytoma, Cushing, thyroid, parathyroid, and aortic coarctation brain tumor. Back to our patient. Our patient, we decide to investigate for secondary causes of hypertension. Already we did investigation. Result showed that TSH and urinary free cortisol and metanephrine and epinephrine for for pheochromocytoma, plasma aldosterone normal, plasma renin activity also, sleep study, polysonography showed or diagnosed obstructive sleep apnea. I'll go brief to sleep apnea. We should all of us consider it in our patient. Sleep apnea is a disorder in which there are repeated episodes of partial or complete cessation of breathing during sleep. It can be central origin or peripheral due to mechanical obstruction of airway or combination of both. By definition, apnea or hypopnea lasting at least 6 seconds are considered of clinical significance for diagnosis, although some patients can reach to 1 minute. Apnea-hypopnea index, or known as respiratory distress index, is the average number of apnea-hypopnea per sleep hour. What is the epidemiology? Epidemiology of sleep apnea and hypertension. There is combination, there is correlation between both? Yes. First, I start with prevalence of sleep apnea. In one study of working middle-aged adult, 30 to 60 years, it found that 2% of women and 4% of men have sleep apnea, and this incidence increase of the age reach maximum at 70 years. Both sleep apnea and hypertension are common, and I'm not surprised you will find the patient has the two, because both of them can be also associated with obesity. About 60% of sleep apnea patients have hypertension. 30% of hypertensive patients have sleep apnea. What about blood pressure pattern in sleep apnea? Sure, there is nocturnal variability of blood pressure in sleep apnea. It can be loss of this nocturnal decrease in blood pressure, sometimes increase in blood pressure, and they suppose it can be to sympathetic overactivity. What is important also, it's found that in resistant hypertension, always common with patients with sleep apnea. In one study, it showed that 83% of the patients with sleep apnea have hypertension, resistant hypertension. Coming to clinical evaluation of sleep apnea, cardinal manifestation, snoring, day sleep. Typical character of the patient, male, middle-aged, obese, and short neck. Routine laboratory will not benefit. Gold standard for diagnosis of sleep apnea, as we mentioned before, polysonography, which can be done in lab and even it can be at home. Treatment of sleep apnea. First, treatment the underlying cause, either surgery or CPAP, nasal CPAP. Second, treat hypertension with lifestyle intervention. Fifth approach. Before starting, what we'll do? What is a common mistake in treatment of hypertension? Use of doses too low, failure to titrate, inappropriate antihypertensive combination, use of short-acting drug, failure to use diuretic if the renal GFR less than 40. So what measurement for secondary hypertension? As mentioned, we can add spironolactone. In patient, it found it is added as the fourth drug, it can be benefit. Why? Because it's found that bromide-aldosteronism is relatively common in resistant hypertension. Around 20% of the patient of resistant hypertension have hyperaldosteronism. Other measurement, device-based treatment of resistant hypertension, either renal sympathetic denervation or carotid baroreceptor stimulation. Last one, referral to hypertension specialist. It is clinical hypertension, certified from American Heart Association. Only 3 subcategory of subspecialty can take this: cardiologist, endocrinologist, and nephrologist. Coming to conclusion, systemic hypertension is the leading cause of global cardiovascular mortality and morbidity. Uncontrolled hypertension promotes target organ damage and significant disease burden on the community. Resistant hypertension is defined in order to identify patients who are at high risk of having reversible causes of hypertension, may be benefit from special diagnostic and therapeutic consideration. Exclusion of pseudo-resistance, implementation of lifestyle intervention, discontinuation of interfering substance are initial steps in approaching resistant hypertension. Workup for secondary causes of resistant hypertension should be reversed for patients with appropriate clinical clues. Both sleep apnea and hypertension are common. Furthermore, both are closely linked to obesity. Thank you.
Excellent, thank you very much. So take 1 or 2 minutes for this discussion of this case. Resistant hypertension, I think, if you truly look at it, is less than 5%. But of course, Doctor mentioned the list of things to exclude. The things which she mentioned, obesity is very prevalent in this country, and Middle East actually itself, sleep apnea. The reason I ask you about the metoprolol, because metoprolol is controversial in somebody with sleep apnea. It may exacerbate. That's why you need to revise it. That's the whole idea behind it. I think you had a question.
Just to comment, there is a paper published by European Society of Cardiology 2021 about using Entresto for treatment of resistant hypertension. Of course, it's not accepted by the company because they don't want that. They want to keep it for heart failure. But it is an antihypertensive drug, by the way.
Thank you, Doctor.
Thank you very much, Dr. Amal, for your excellent presentation. My question is regarding your patient. If he presents to you with a severe hypertension, would you directly start him on a combination therapy as recommended by guidelines, or you prefer to start him and then see him later and add on other medication from another category? Thank you.
For a nice question, but according to guidelines over European Society or American Society, even Canadian Society, we should start with combination therapy. I am not wait to be his severe hypertension. Even in a stage 1 hypertension, you can start by combination therapy in low dose and increase the dose. So now this step treatment is not allowed, and I think it is considered as a crime nowadays, because why we use combination? To take the benefit of 2 mechanisms or 3 mechanisms of action for hypertension. As mentioned, Doctor, hypertension is not a number. It is a systemic disease. So combination should be.
So in resistant hypertension, if it's truly diagnosed based on the criteria Doctor mentioned, we still have, I know you heard about RDN, renal denervation. It's available, and the data is coming. Randomized clinical trial is really supporting, but again, and where they do this in a huge number, where the experts should be there, because sometimes Mickey Mouse, you hear about, here and there center, they do this. Don't give it to people who do it once a year or twice a year. Give it to people who are doing it on a regular basis. Any other questions? I think we still have time. Dr. Hani, where is Dr. Hani? Is he here? We still have time. Questions? The whole program, hypertension, we had from beginning to the doctora. Any questions to the Dr. Sharif? تفضل دكتور. Give a mic. تفضل دكتور.
Thank you very much. Thank you, Doctor.
Thank you.
It was very interesting talk. Nowadays, we have, instead of aldactone, which is used for the resistant hypertension, as you know, there is medicine which is finerenone. And this is a non-steroid anti-RAS. And it doesn't cause hyperkalemia like the aldactone, and also it doesn't cause gynecomastia, etc. So finerenone is available in 10 and 20 milligram. And it is especially useful in patients with diabetic nephropathy with hypertension because it has very good effect on the progression of the kidney disease. Thank you very much.
You talked about finerenone? Yes. Finerenone and hypertension?
Yes, instead of the aldactone.
Finerenone in diabetes, chronic kidney disease.
Yes, but
in hypertension, do you have a guidelines? Anything to suggest
no,
that?
this is instead of the aldactone. As
I know the medication itself, I know. But I'm saying, is it established in hypertension?
No.
If it's not, then we have to be careful.
Return back to the first question, sorry, your question. I think the guideline 2023 was very clear. Yes. You have to start by dual combination.
Yeah.
No way now to start by
Monotherapy.
single drug. So I have to start by dual combination and then it change the dose, and then after that.
One exception in fragile patient whose blood
Fragile
pressure-
patient, this is another story.
Oh, yeah.
Because
The only
fragile
exception
patient,
to be
there are a lot
monotherapy.
of, this is different category.
Yeah.
But guideline was very clear.
combination therapy. Thank you, doctor.
Yes, تفضل.
I think the key answer in this situation, the patient should lose weight. Even in the guidelines, they said almost 1 kilogram equal 1 millimeter mercury drop in the blood pressure, the systolic and diastolic. So I think in this patient, the magic answer for him is pediatric surgery.
Yes, it's clear. But
This is the best-
why we proceed all this? Because obviously we cannot keep the patient with all this medication, uncontrolled blood pressure, till plan for bariatric surgery. Insurance will do. He will pay by
But it
himself.
should end with
But
bariatric surgery.
his clue is reduction of bariatric surgery.
The guidelines is
Because
very
he did
clear.
his best.
So
he did a lifestyle.
BMI is 47. You have an options a lot nowadays. It's not just bariatric surgery. You have
The problem,
Habib
Dr.
Manjaro. You have other things. There are lots of medication available to help. And should not. People don't like invasive in this country. Go something simple.
دكتور بعد اذن حضرتك هو the problem Monjaro even I think you can give me more experience in that, but most of patients who stop Monjaro again they gain weight.
Yeah.
I have in the family 2 had bariatric surgery. They gained weight, and now on Monjaro.
Half of them.
So it's, any other questions, comments? To the whole team, the Sharif is still here, he had a talk as well. دكتور كثرت السؤال عليها في دكتور ثاني بعدني. Any other questions? Or you have a break? I think we need to have a break, صح? After all this. Let's have a break. Thank you.
Okay,
Only
thank
10
you.
minutes, huh?
Thank you.